Well, it would be ideal if we could treat each individual patient as an individual. Right now, we unfortunately have a one-size-fits-all start, and it's nice to be able to try to manipulate medications when possible. And so I think that we struggle in the fact that there is dramatic differences in patient response to therapies and metabolism. It would be nice if every patient behaved in a similar fashion, but unfortunately we do see tremendous variation in metabolism, in response to therapies, and each patient has their own risk factors that they bring. So I think that a huge focus to what we're trying to do is not only identify differences in patients, but identify different medications and different strategies for an individual patient. So this is I think a pretty important point, because I don't think anyone has really studied the pre-transplant donor-specific antibody in the absence of immunosuppression management for that. So I think it opens the door for patients to be transplanted perhaps a bit safer in the first few months to even years after transplant. We're not going to have to be using dramatic interventions for a low-level donor-specific antibody. What we don't know is the 5-year data or the 10-year data. And so I think that what it means for patients in terms of immunosuppression regimens is that it is safe to do, it's safe to perform, but I think that in my mind there's still a word of caution in terms of interpreting long-term outcomes. So the concept of testing for genetic polymorphisms that might predispose to renal disease, I think, is a very topical and very interesting and moving field. The APOL1 polymorphisms clearly confer some risk, but how much that risk is truly attributed to just the genetics versus the other clinical factors that are incorporated within an individual who has APOL1 polymorphisms is still very, very controversial. And so I think for us to be testing in the deceased donor setting right now, we are now looking to see if APOL1 has added value above and beyond other clinical risk factors, such as just race defined as black or white. And so while I think the field generally believes that there's a more specific identification on an individual deceased donor level, I think globally it will be a challenge to necessarily implement. I think for the patient who receives a deceased donor kidney transplant, whether or not that information actually can help monitor or manage the patient is probably too early to say. I think that we really are now identifying, potential glomerular diseases post-transplant that could be related to APOL1 polymorphisms in the donor. So hopefully in the future what we'll have is a lot of good clinical robust information about the genetic polymorphisms and outcomes, predominantly in living donors, prospective living donors, but also whether or not it adds true value and not risking our deceased donor allocation policies. I think that the issue of trying to improve outcomes from point A, which is the time of transplant, until point Z, is really a matter of a lot of clinical management, but also a lot of identification. So we need new biomarkers to try to tell us exactly what's happening. Do we continue to rely upon surveillance biopsies? Are there other features, such as genomic analysis of blood or biopsy tissue or urine, that we can truly see and make an actionable decision upon those? I think that these are coming. I think that this meeting essentially defined a number of potential targets that we can explore, and I think it's very exciting for us to see if the biomarker arena can truly help us manage our patients on an individual level better. So trying to determine more frequent monitoring versus newer tests, I think that this gets at the interface of what's happening to the patient and their adherence profiles and their ability and interest in management. And I think that it's probably going to be on both fronts. I think that there has to be a dedicated clinical activity that dictates adherence strategies as well as better monitoring techniques. So patients who have been exposed and have had a failed transplant, they clearly have an immunologic memory, and that memory is a challenge for matching and allocation at the very beginning. But I think over the long haul for a second transplant, while these patients can do quite well and do quite well, I think that there's an enhanced physiologic baggage that comes with that prior exposure. So most of our trials are dealing with fairly low-risk patient populations, and I think that not only the second transplant recipient, but other risk factors need to be considered on the individual level. So as we listen to abstracts and as we look at the meeting findings, it all has to be taken into context of this is most likely the lowest risk, best monitored scenario. And one of those risks that really add to our lack of interpreting the data is repeat transplant and immunologic memory. Yes, so my hope is that there's consortia that are being developed not only with pharma but with our transplant societies to truly try to wrestle with this problem of a lack of development of new agents in our arena because our endpoints are just so stringent and so difficult to compare. So the classic triple endpoint is we have outstanding outcomes that we cannot typically beat in a one-year study. So I think that to aid future development, we need to look at potentially histologic markers plus GFR parameters, and in particular we need to make it easier in terms of costs of clinical trials and perhaps using more of a generalizable, acceptable control arm that could be globally applicable across a number of different either pilot or large-scale trials. So I think that there's some emerging data in terms of exposure and peak to trough data that I think Dr. Bloom spoke in a midday symposia that truly identifies a potential value and pharmacokinetic difference in the African American population. So rather than continuing to escalate dose with BID medications, essentially increasing the peak but not really affecting the AUC or the trough. I think that this is some fairly intriguing information that may lead to once-day dosing in a more routine fashion. At least in terms of CNI exposures and immunosuppression, I think that the genetic polymorphisms that exist in terms of metabolism really focus upon quite predominantly the African American population.